We are going to get started with this week's Pulmonary Grand Rounds. I'm very excited to introduce you to today's speaker, which is Dr. Astha Chichra. While we all know Astha well, let me share you a little bit about her background and her many accomplishments. After completing medical school in Kasturba Medical College in India, Astha trained at North Shore LIJ for residency as well as fellowship. And after finishing her pulmonary critical care training, she was recruited as faculty at Tulane, where she emerged as a leader and served as director of respiratory therapy, followed by a stint as a MICU director. We were delighted to recruit her to Yale in 2018, and she's been a really important part of our core critical care group. Her clinical interests are in all things ICU, but in particular, Astha has had a special focus and POCUS and has served as not only the local regional education lead, but in a national platform as well, such as through CHEST. She's a sought-after speaker and educator, especially in topics related to diaphragmatic ultrasound, ECMO, and POCUS. She has been involved in clinical research and numerous QI and safety projects. At Yale, she holds many administrative roles, including as my partner in crime as Associate Medical Director at York Street MICU, and additionally as Medical Director of the 10-7 Progressive Pulmonary Care Unit. During her tenure in this latter care arena, she led the effort to standardize chronic vent weaning, helped create the chronic vent weaning care pathway, and led the expansion of the 10-7 chronic vent unit, which used to be a 6-bed capacity to 16 beds and beyond in the aftermath of the COVID first wave. She has a wealth of insight as director of 10-7 Progressive Pulmonary Unit in the management of chronically ventilated critically ill patients. And I'm really excited to hear about and together think about how best to care for this vulnerable, ever-growing, and challenging patient population. Thanks, Astha.
Thank you. Thanks for that lovely introduction, Shioko. Can you all hear me okay? All right, I won't use this one then. So this is for your CME. I have no disclosures related to this activity. Okay. So here are my objectives for today for this sort of huge topic of chronic critical illness. So we will define chronic critical illness, review its outcomes and pathophysiology. Like the talk, the title mentioned, I'm going to focus more on the patient population that requires prolonged mechanical ventilation. So we will define that. We will discuss available literature on ventilator weaning strategies in this population. Briefly review decannulation approach for trach patients. Overview of nutritional deficits in this population, because really this is a talk by itself. And then briefly talk about palliative care in chronic critical illness. So chronic critical illness was first coined by Girard and Raffin back in 1985. It describes a subset of patients who continue to require intensive care therapies after an acute critical illness. And this paper that was published in Respiratory Care in 1985 is particularly thought-provoking and insightful and really forward-thinking. And I would encourage all of you to read the paper. It's really a lovely read. In fact, I'll take a minute and read some of their abstract out to you to show you how forward-thinking the authors were. So they say in the abstract, critically ill patients admitted to an ICU are rapidly evaluated and aggressive management is immediately instituted. They're intubated, placed on mechanical ventilation, and invasive monitoring is begun. Many patients are successfully treated and discharged from the ICU, but unfortunately, a large percentage of these patients do not improve and become chronically critically ill. A high percentage of these patients do not survive in spite of extraordinary life support for weeks to months. The ICU healthcare team and the patient's family use their collective judgment to determine which patients are salvageable and which patients have no realistic chance to regain a good quality of life. and therefore should have extraordinary life support withdrawn. This article examines why chronically critically ill patients die. We present a management strategy for improving the prognosis of these patients by concentrating on exercise, nutrition, fluid management, emotional support, and get this adequate sleep also. We address issues dealing with withholding and withdrawing extraordinary life support. And then they conclude by demonstrating how they use these concepts in a young patient with AIDS. So really very thought-provoking, really covers almost all the topics that we will be trying to touch upon today. And like I said, a really good read for our fellows, certainly. If you want a copy of the paper, let me know. Okay. So going on to now the definition of chronic critical illness. So this is the consensus definition of chronic critical illness that has been developed and approved by CMS. So per CMS criteria, these are patients who receive care in an ICU or CCU setting during their hospitalization and have one or more of these conditions, which include tracheostomy, prolonged mechanical ventilation, which for this patient population or this definition's purposes was requiring ventilation for more than 96 hours, multi-organ failure, sepsis, other severe infections, or severe wounds. Prolonged mechanical ventilation, like we said in the prior definition, was more than 96 hours. And there are a whole host of definitions for this particular entity ranging from 96 hours to some 7 days, 10 days. But again, the CMS criteria here is greater than 21 days of mechanical ventilation for at least 6 hours per day. And prolonged mechanical ventilation really is a hallmark feature of chronic critical illness. While all patients who are chronically critically ill are not ventilated, but a majority or almost all patients who require prolonged mechanical ventilation have chronic critical illness. The burden of this disease entity is enormous. It leads to more than 100,000 hospital deaths per year and over $25 billion in hospital costs per year. The leading admission diagnosis that leads to CCI is sepsis. An estimated 4 to 13% of all comers of intubated patients in the ICU end up requiring PMV. And this 4 to 13% actually accounts for 37% of ICU costs. So really a huge financial burden too. And this data predates the COVID pandemic, and it has likely increased since we know that in the last 5 to 10 years, complexity of patients is only increasing. What are some of the outcomes of these patients? They unfortunately still remain dismal. So back in 1985, when Girard and Raffin first coined this term to now, the outcomes have still unfortunately remained fairly poor. The mortality is almost 50% 1 year post-discharge from the ICU. Out of these survivors, only about 20% have persistent physical and cognitive impairments, and only about 10% return home at the end of 1 year. And the trajectory of these patients is quite known to us. It's characterized by ongoing complications, infections, rehospitalizations, and intensive therapies. And this leads to prolonged hospital stays, cost of care goes up in the billions of dollars per year per patient. What do we think is the sort of the pathophysiology of chronic critical illness? The leading theory behind this is that it's a state of persistent inflammation, immunosuppression, and catabolism. And what that theory means is that something in the host leads to a dysregulated and maladaptive cycle of persistent inflammation, which causes this vicious cycle of reduced immunity, multi-organ dysfunction, and neuroendocrine changes. It is really unclear why a subset of patients are more susceptible to this. We do know that higher incidence is seen in the elderly, those with chronic comorbidities, higher Apache scores, but unfortunately, we don't currently have any good biomarkers to help predict this condition. So really, the thought now is that the chronic critical illness is a whole constellation of features that constitutes a syndrome. So a patient with acute critical illness, maybe with older age, more comorbidities, sepsis as the leading cause, all of this predisposes them to develop chronic critical illness, which has all of these characteristic features, including prolonged mechanical ventilation, malnutrition, skin breakdown, neuromuscular weakness, increased susceptibility to infections, brain dysfunction, endocrine changes, cognitive impairments. Now, just shifting gears a little bit and talking a little more about the prolonged mechanical ventilation population and ventilator weaning in this population. Up to 50% of patients have been known to get liberated from mechanical ventilation of those who require PMV. A majority of the patients who do achieve ventilator liberation do so within the first 60 days. And so it's really important for us to concentrate our efforts in that initial period. And in terms of ventilator weaning, we would suggest that every patient requiring prolonged mechanical ventilation or otherwise should be assessed for readiness to wean, just very similar to our acutely critically ill patients in the ICU. How do we assess that readiness? These criteria were by an expert consensus group, very similar to our weaning protocols in the ICU. So the patient should have adequate oxygenation, which is evident by, FiO2 that's not too high, a PEEP which is in reasonable range. They are hemodynamically stable, afebrile, they don't have respiratory acidosis, and they're otherwise adequately awake and resolution of the acute disease phase. Now, level of consciousness, of course, here is not considered a barrier in this population because of the presence of a trach. What about weaning protocols? So we think the patient's ready to wean. We think we should be assessing them every day. That's great. Should we be using protocols? And some of the terminologies that come about when you talk about protocols are that it's too rigid. It's a cookbook style of medicine. It sort of loses the art of medicine. And these are very common arguments amongst many more against any protocols. And I think the point to really emphasize here is that while no single protocol can cover every patient scenario for vent weaning, we do know that the utilization of protocols will help provide better care for a majority of the patients. And this was actually very well shown in this study that was elegantly done in an LTAC setting. It was an observational study of about 250 patients who required PMV. And they looked at whether the patients went through usual weaning, which was physician-led weaning, versus a respiratory therapist-driven protocol. And they showed that if the patients who were in the arm of the respiratory therapist-driven protocol, their vent weaning time was significantly shorter than the other historical controls. It was actually a big difference of 17 days versus 29 days. And so really, there have been more studies since then suggesting more of the same. But the suggestion really is that maybe using a protocol is more important than the weaning strategy itself in these patients. A point to be noted is that in this particular study, they used a RISB of 80 as a cutoff, so fairly conservative to go on to that respiratory therapist implemented protocol. Since then, the same authors actually studied this more and suggested that maybe we could liberalize this a little more and go to a RISB of 97. What about strategies? So unfortunately, like many of the things in this patient population, we really don't know what the optimal protocol for weaning in these patients is. And so some of the common strategies that you may see are intermittent mandatory ventilation, pressure support ventilation, unassisted breathing using trach masks. Do we do it once a day? Do we do it many times a day? We've seen a combination of all of these. And really what the best strategy is not clear, but we do have some suggestion from available literature that we can use in this patient population. So this was an old study by Esteban and colleagues published in New England Journal of Medicine in 1995. This was a randomized multi-center study of more than 500 patients where they looked at patients who were considered to be ready for weaning. Specifically within that population, they looked at patients who failed a 2-hour trial of spontaneous breathing. And then these patients were assigned to one of the 4 weaning techniques that we discussed, which included intermittent mandatory ventilation, pressure support ventilation, spontaneous breathing, both once-a-day trials or multiple times a day trials. And they found some really important things. So the first thing they found was that compared to intermittent mandatory ventilation, or SIMV as we call it, once daily trial of spontaneous breathing had a statistically significant rate of successful weaning. So spontaneous breathing is probably better than SIMV. The second thing they found was that spontaneous breathing also was superior to pressure support ventilation. And thirdly, they found that there was really no difference between doing once-a-day trials or multiple trials in a day. It didn't lead to any faster weaning in any way. Again, this is just a Kaplan-Meier curve from that particular study. These two on top are the spontaneous breathing curves, both once a day here and intermittent of spontaneous breathing. And then these two are the SIMV and pressure support. So really, maybe we got a hint from that maybe just spontaneous breathing trials are the way to go in this patient population. And this was maybe one of the largest study in this population done for vent weaning, where Gibran and all, they published this in JAMA in 2013. They looked at patients requiring PMV who were admitted to a single LTAC, so single center study. And they randomized patients over a time period of about 10 years, whoever came to this LTAC. What they did was all comers to this LTAC was screened by a 5-day screening procedure where all of the patients received a trach collar trial, essentially. Those who passed this 5-day screening were considered to be liberated from the ventilator, but those who failed, which was about 316 or so of the 500, were randomized to either a pressure support group or a trach collar group. They further subdivided these groups that they were randomizing into 2 groups, the early failure group, or those that failed the trach collar within the first 12 hours, or the late failure group, which was those that failed trach collar after 12 hours. And they were looking at primary outcome of weaning duration and secondarily at survival. And they found 3 very important things in this trial. So first, they saw that trach collar use versus pressure support. Trach collar was clearly superior. It resulted in earlier weaning than did pressure support in these patients. The difference was about 15 days versus 19 days. And secondly, the influence of the weaning method on successful weaning was more pronounced in the late failure group. So these were the patients who failed trach mask after the 12 hours. And the thought behind this was that this difference was more related to the fact that the early failure group was probably sicker. They had less endurance than the late failure group. And so that probably had more of a influence in the weaning outcome. These patients were just too sick and not ready to wean. And thirdly, there was no difference in mortality in either of these. There was no significant adverse event in the trach collar group versus the pressure support group. And so really with that, with this available literature, we really can take away one thing, that maybe patients who require prolonged mechanical ventilation, spontaneous breathing trials are likely the way to go here. And so with that, we did craft these guidelines for vent weaning in this population, which is hopefully familiar to all of you with the weekly emails that you get from me about these. But essentially, it outlines weaning criteria, SBT criteria that's very similar to our acute population in the MICU. Every day, RT will screen the patients, see if inclusion criteria is met, and then we encourage them to do a SBT for 30 minutes. If they pass the SBT, then the patient goes to trach mask. And the way we did this is really mirroring that JAMA trial where we said day 1 and day 2 you can go up to 12 hours on trach mask as tolerated. And then day 3 of trach mask trial, they can go up to 24 hours. If the patient fails trach mask, then there is an arm which lets you go to pressure support. And the pressures of that right now are more provider-driven, I would say. So you can decide and titrate the pressure support to the patient's tidal volumes, respiratory rate, and their comfort, and sort of go up or go down based on that. So this arm is there for patients who fail, but really it is encouraged that you go to trach mask in these patients. So again, here on 10-7, what we say, our takeaway was also that we are only doing this once a day, not many times a day. We know that in no way is doing SPTs multiple times a day superior. Unassisted breathing using a trach mask is our way to go for these patients. It should be used as standard for anyone who passes SBT. If they fail trach mask, certainly you can use a pressure support weaning strategy, and you can rest on pressure support also for patients' comfort, but to be clear, the understanding should be that this is more for patients' comfort and synchrony with the vent and not really a weaning strategy per se. And then a plug about the pathway on EPIC, please use this. This will come up under liberation from mechanical ventilation for chronic respiratory failure. It has the same flow chart is all on the pathway, and it guides you step by step on that. What about non-invasive ventilation for weaning from prolonged mechanical ventilation? So this is an additional approach that can be explored to assist in the weaning process for some patients who require partial dependence on mechanical ventilation. And I'm sure you've all come across those. We have a couple every year on 10-7 too that require this. So, while we don't have very good data to support this, we do know that NIV is effective in reducing ventilation duration in acute respiratory failure scenarios. And this can be extended to prolonged mechanical ventilation as well. With this thought, many authors have done small-scale studies reporting the application of NIV for ventilator liberation in the PMV population. In particular, this was one of the more recent studies where this was done in Italy in a weaning unit, where they looked at about 46 patients who were not able to be fully liberated from the ventilator. But they were able to tolerate more than 8 hours of unsupported breathing and then failed due to hypercapnia. They also met other criteria for using non-invasive, which was standard, and criteria for decannulation. And then these patients were transitioned to nighttime NIV usage after they downsized their trach. They really rigorously monitored them with daily blood gas measurements, mask fittings, ensured the patients were tolerating NIV. And then once patients were doing well, their blood gases were stable, they underwent decannulation and were sent home on NIV nocturnally. And after 1 year, they followed up these patients, and they saw that 38 were alive and 37 were actually still on NIV, with only 1 requiring invasive ventilation again. So this is a strategy that could be used in a selective subgroup of patients, I would say, that should be thought about. So how long do we try before we say, this is enough? So we have some data to it. Usually when we look back at these patients, at least most of them spend about a month in an acute setting and about another month outside the ICU as a minimum. And so the expert consensus group here again says that you should try for at least 3 months before saying that weaning has failed. And really, practically speaking, we've seen these patients where usually if there's something acute happening, these 3 months usually is extended under extenuating circumstances. But in patients who fail weaning, it is really imperative that we talk with the family and patients about what we think the prognosis is, what do we think the long-term outcome is for weaning. So a word about capping and decannulation. Again, when you go to that pathway for liberation for chronic respiratory failure, it gives you a link for the decannulation pathway as well. This was crafted by our IP team led by Dr. DiBiase, and it goes through sort of a checklist. So now the patient's liberated from the ventilator, they are tolerating trach mask 24 hours a day. what do we do to decap them and decannulate them? So our usual protocol is that we want to make sure they're awake, they're able to tolerate being capped, they have an effective cough, they can handle their secretions, their upper airway should be patent, importantly, and their oxygen requirements are under 35%, so we can support them with a nasal cannula. Well, when we quite simply put a cap, we do suggest getting an ABG pre and post trial, and then you could consider decannulation. If they fail, this is where you probably want to involve the experts of IP, ENT, surgery, whoever, but you may need a bronch to evaluate the airway, make sure there's nothing like a granulation tissue, anything else that could be contributing. You may want to trial downsizing the trach or just try a shorter trial for those who are very agitated. So that's been the standard sort of capping protocols in most places that I have been to. This was a more recent study which had a slightly different thought about the process. This was published in NEJM in 2020. It was a study out of 5 ICUs in Spain, and they looked at decannulation outcome using 2 protocols. So one was the usual capping trial with intermittent oxygen therapy as needed that we are very used to. And this other arm was intermittent high flow oxygen therapy, and they would monitor their suctioning requirements. So they really were basing readiness to decannulate based on suctioning requirements. And they found that the group that got high flow nasal cannula continuously with just monitoring of suctioning actually had a shorter time to decannulation of 6 days versus 13 days. And they also found some lower incidence of infection incidentally in that particular group, maybe related to high flow nasal cannula or maybe the removal of the trach faster. So quite a novel therapy. They, assessing readiness based on suctioning requirements, which they defined as less than twice every 8 hours for a 24-hour period. And so it does, give some food for thought about whether we could be using a different strategy for some of these patients. This is obviously more resource intensive, requiring high flow nasal cannula, and maybe is not quite ready for prime time use here, but maybe something to think about. So what are the complications of PMV? You'll see these are very similar to the chronic critical illness syndrome that we spoke about, with infectious complications, skin breakdown, nutritional deficiencies, thromboembolic events, and neuromuscular deconditioning. I think important thing to, of course, be aware of are airway complications, including loss of airway. So anyone who's had a trach for less than 7 days, that tract is likely not mature and does require emergent airway replacement. And then this particular entity called tracheoinnominate artery fistula, it's very rare. Its incidence is about 1 to 2%, but mortality is upwards of 75%. When this happens, mostly patients have a sentinel bleeding event first, which is very small. It's usually about 10 to 20 cc's. But when that does happen, you do want to take a step back and think about it and make sure you are really closely monitoring these patients. And then the usual of granulation tissues, stenosis. Once you decannulate them, some of them may have persistent stoma and complications related to that. So now talking a little bit about the nutritional deficits during chronic critical illness. Malnutrition is obviously a prominent feature of both chronic critical illness and PMV. This is also caused by a vicious cycle of chronic inflammation, relative immunosuppression, hormonal imbalance, and it causes significant loss of lean muscle mass, which continues despite surviving that acute phase of illness. And these patients go into a prolonged state of catabolism, which is characterized by poor wound healing. They get ulcers, and this this leads to more symptom burden and morbidity, ongoing muscle mass loss, and creates this vicious cycle that is very hard to overcome in these patients. We don't have great data to say what we should do during chronic critical illness. Typically during acute critical illness, which is our first week or so, really within the first 5 days, we know that it is acceptable to go up gradually on feeds, maybe reach up to 70 to 80% of full goals. We do always want to think about early mobilization that goes hand in hand. In the subacute phase, you really want to really hit that full feed target, which can be based on weight-based calculations or otherwise. And this chronic illness where we are focusing on, where they are now maybe out of the ICU, that is the one that is pretty hard to figure out what do they need, because their needs are constantly changing. And the reason for that is that the weight is constantly fluctuating based on fluid retention. There's changes in muscle mass. It leads to changes in body composition. Their energy expenditure is constantly changing based on how much physical therapy they are doing. Are they undergoing ventilator weaning or not? And so really weight-based calculations are sort of fraught with error in this population a lot of times, and could result in both under and overfeeding depending on the scenario. So the gold standard is supposed to be indirect calorimetry, which unfortunately we don't have here. It was a modality that was very resource intensive, sort of cumbersome, large machines, but more and more there are now these machines that are nice and small. You may have seen them when you went to ATS or CHEST. They show them a lot of times. And I think could be where we may be headed with all our critically ill patients eventually. And of course, one of the other really important entities in this syndrome is ICU-acquired weakness. This is inclusive of both critical illness polyneuropathy and critical illness myopathy. And a lot of patients have a combination of both, which is critical illness polymyoneuropathy. So critical illness polyneuropathy is caused due to distal axonal sensory motor polyneuropathy, and it affects not just the limbs, but also respiratory muscles. And then the critical illness myopathy is muscle dysfunction. It's usually compounded by decreased muscle mass, disuse atrophy. There is an imbalance between increased proteolysis and disuse, and that leads to further impaired muscle contractility. Again, we know factors that could be increasing the susceptibility of patients to ICU-acquired weakness, including increasing age, increased ICU length of stay, increased burden of comorbid illness, and then also other risk factors like cognitive dysfunction, patient mood, even caregiver mood or health plays into this. And all of this sort of leads to this vicious cycle, which leads to persistent disability and ICU-acquired weakness in this population. So there isn't, again, great data to examine the benefits of physical therapy in chronic critical illness, but it's really unlikely that randomized trials will be done in this population. The benefit is inferred from all we know in acute critical illness. And we do know, though, for a fact that there have been studies done in the prolonged mechanically ventilated population that does show that intensive PT and rehab early on does lead to increased ventilator liberation. So, okay, we did all of that, but the patients are still not doing so well. You know, their trajectory, like we mentioned, is usually complicated by multiple infections, skin breakdowns. They have trips back and forth from the ICU. And what do we do next? So palliative care, of course, plays a big role in chronic critical illness. The burden of chronic critical illness is not just on the patients, but on caregivers, family members, and on healthcare systems like we described. Families and caregivers have reported significant decline in their own physical and mental health, with symptoms of depression, caregiver overload, stress, and financial strain. And as clinicians, all of us tend to place an emphasis on immediate outcomes after tracheostomy and prolonged mechanical ventilation without maybe clearly communicating what the expected trajectory is for these patients that we've seen, that we know of based on studies over months and years. And so as a result, patients and families are often not prepared as to what to expect in the coming months. So it is really important that we have objective and clear discussions with clear outcome discussions with families, patients, caregivers as to what to expect, what transitions can they expect after a trach or prolonged mechanical ventilation. And we actually know this in this study by Cox. They looked at families and caregivers' expectations versus clinician expectations. This was done at Duke on about 120 patients, but really stark differences. These were not small differences. The study found that family members and caregivers were more likely than clinicians to expect the patient to be alive at a whopping 94%, versus clinicians who only expected them to be alive at 43%. The patients and family members expected that patients would lack major functional limitations at 71% versus 6% for the clinicians. And again, family members and caregivers had an expectation of a good quality of life for their loved one at 83% versus 4% from the clinicians. And these were all one-year outcomes that they were talking to them about. So really big differences, and maybe somewhere as clinicians, we are not able to translate what we are objectively seeing. We have data to back this up to family members. And the truth is, it is hard. There's no clear guideline in how you communicate with these patients and caregivers about these topics. In fact, there are studies that have reported increased PTSD in families and caregivers when you've had reiterative discussions about palliative care approaches. And this is a well-established fact. But really, how the lack of understanding in the patient and family givers, impacts their decisional regret, their burden is also not known. And so again, it has to be an individualized approach. So every patient and family is different, and having a patient and family-centered approach to try and meet them is warranted. And what is maybe important is to periodically reassess their wishes, because what they may wish at day 14 coming out of the ICU may be different at day 30, day 60. And so periodically sitting down with them, explaining what you're seeing and what you think the outcomes would be is very important. So with all of this, hopefully I've convinced you to say that chronic critical illness is not a disease entity that one team can manage. It really requires a multidisciplinary team approach. And not just of physicians, but really of nurses, social workers, respiratory therapists, nutritionists, physical therapists. We need to focus on all of these entities to improve their outcomes, which is a tall order, but that is what we must do. So, think about what the best vent weaning strategies for them is, while giving them adequate nutritional support, while trying to prevent infection and other complications, while improving their cognitive function, reducing delirium, and then integrating all of this with palliative care. So I think a really multi-pronged approach is required in each and every one of these patients to improve outcomes in any way. So to conclude, with an aging population, rising comorbidities, increasing complexity that we know for a fact, we know that chronic critical illness cases are expected to rise. We know it'll have a significant impact on morbidity, mortality, along with high economic burden. And so it is really essential that we invest in high quality research and care models for this population. We need well-designed studies to determine the best nutritional, vent weaning strategies for this patient population. And it is crucial to have open and transparent discussions with patients and their families about what we think the outcomes would be. That's all I have for all of you, so thank you.
Thank you, Astha. That was an amazing, comprehensive, really informative talk for a topic I think near and dear to many of our hearts. We live and breathe this. We'll open both the Fitkin here as well as the online folks for questions and discussion. I see Margaret. I knew you would have a comment.
It's a practical one. Astha, do we have any routine protocol or expectation to involve palliative care in these patients? Or is it just kind of on a if we're struggling, you know?
Yeah, no, actually, we have done a lot of work with palliative care in this population, at least the prolonged mechanically ventilated population on 10-7. And I really thank Dr. Capo and her team to support us, but they actually have been joining our rounds, our 10-7 rounds once a month. And they listen to the discussion of all the patients, sort of ensure they're on board. And as needed, actually have even, we've even had multidisciplinary meetings with palliative care once a week with some of the more complicated patients. We have a lot of support from them, and I think it's, we could always do with more though. So.
I think there have been some studies looking at automatic triggers for palliative care consultation. There was just an article that came out, I think, this week. It helps in some respects, but it's not really clear what the right, I think, trigger is and what the benefit is actually for different patient populations. And so I think for us, we've used a little bit more of a nuanced conversation approach rather than an automatic trigger. Mark?
Thank you, Astha. You know, I thought it was really interesting that your care pathway just leaves a lot to the discretion of individual clinicians when it comes to using PSV weans.
Mm-hmm.
And when you go back to this really classic study that you quoted by Esteban, a lot of people have interpreted that study as saying, well, the reason people got off the ventilator faster with the T-piece versus the IMV and the PSV was actually the T-piece is actually a test. It's not really a wean, right? What it shows you is the patient doesn't need the ventilator anymore. And if you give them support, you don't know that. And so do we think weaning does anything? Because I'm curious, so we spend so much time, like 2 hours of PSV of 10, and then maybe they'll go down to 8, and tomorrow they'll do 6.
Yeah.
And I think if we could just cut out all those conversations and just say it really doesn't matter what you do, they'll be ready when they're ready. So what do you think? Does PSV do anything?
I think that's a good question. So so the question that Mark posed was, does weaning do anything? And I think that is a big question mark. We don't honestly know the answer to that. I do believe that high pressure support does not do much, which is why I emphasize that just resting patients on pressure support is not really a weaning strategy. I think, at lower pressure support, are we at some level, preventing weakness of respiratory muscles? Are we in some way reducing or kind of regenerating the diaphragm in some way? I don't know the answer to that. And there really haven't been very good studies to that head to head. So I don't think we'll know. I do think it makes us feel better that we are doing something. And intuitively, I think it makes sense if someone is doing a pressure support trial. It also comes along with a whole host of other things, which is that we have them awake, we have them sitting up, they're participating in PT, they're more synchronous with the ventilator, which by itself has been shown to reduce deconditioning of the diaphragm and other respiratory muscles. So I wonder if all of that plays a bigger role in it. I think the fact that the other point that you mentioned, which was that our protocol leaves a lot to the clinician, is true. I think it's because every patient is so different, but there may be changes coming to that, so we will keep you posted.
So first of all, thank you for actually trying to protocolize something that has been. You have to talk a little bit. Oh, sorry. Thank you for protocolizing something that, and working with people to actually do something that's been really challenging over the years. I had similar questions to Margaret, not just with palliative care, but, you talked about sort of a multi-pronged approach, and how is that all? I have so many questions, but how is that all working? Also talking about transition of communication and things like that, facilitating communication as well. I think on consult service, we often go to those Thursday 1 o'clock meetings and trying to figure out what our role is there. Actually, I don't know if you're having separate meetings where you have sort of this multi-pronged conversation, because I think that would also be, really interesting and helpful. I mean, I could probably ask 10 more 10 more questions. And also, what would you like to see in the future? What are you
Yeah.
working on? Like, what are you trying to?
Yeah, I think those are great points. I think the challenge is this multidisciplinary team approach really is to get all the resources of everything we need, and I think to a certain degree things have improved over even the time that I've been here since before I was a director, where I think your first question was about continuity, I think, of care and transition of care. And we've ensured actually that there's just one group of hospitalists that rotate through Trend 7. So Tuba Kazmi, who many of you may know, is sort of my partner in crime in 10-7. She's a hospitalist director. And she worked really hard with hospital leadership to change the staffing model of 10-7, because we all know these patients are here for a while. And to ensure consistent care is really important, where otherwise the first 2 or 3 days of every new hospitalist is spent figuring out what's going on with them. And so that has helped us actually, somebody who's looked at the data about staffing models and our rates of ventilator liberation and decannulation in the hospitalist group. And they found that with the staffing model change, we've seen a really significant improvement in vent liberation and decannulation both. So that's something that is actually in the works right now. The other, and similarly with the hospitalists, the APPs also are fairly consistent within the hospitalist group. There's a particular sign-out format, note format that all of them follow to ensure they all have significant pieces of information like trach size, which service owns it, etc. I think the one part that we are struggling with is, of course, consistency with the pulmonary team, which is going to be hard to achieve. But I think our fellows are the biggest consistency that we have, and have really been big drivers in care of this population. So thanks to them for that. I think the weekly huddles with the pulmonary consult team help in ensuring effective communication between the clinical teams, but also RT is supposed to sort of be joining in that. And then separately every week, actually, I have a meeting with the hospitalist team, with case managers, social workers, palliative care joins in once a month that I mentioned. Ethics actually joins in if needed as well, to ensure that care keeps progressing as the pulmonary consult team switches. I think so. There's a separate nutritionist for 10-7 who's also very involved, and there's been effort from the RT staff to actually ensure that same RTs, to the best of their ability when they're working, certain RTs actually have a preference or they are more likely to be on 10-7, which has been a big help for the hospitalist team. And so they've helped us a lot with that. And I think the last piece is physical therapy, which I think we could do much better with. And I think the good news, your last question was, what are you working towards to improve care? And I think the big thing that we are working towards is that actually the hospital has recognized that this is a big population that has not come down. I think we all thought that 10-7 expanded after the COVID pandemic and it would shrink back down to that 6 to 8 beds. And it has not gone down, where we are always at 16 beds with the wait list, and spilling over to 4-6. So I think the hospital has recognized that, and they are willing to put more resources in it, so more to come with that. But we are very excited that we may be able to get more physical therapy for a subset of patients who are able to participate in PT and we feel are weanable, and so we really want to target them in that first 60 days with aggressive PT, nutrition support, and care management resources.
Great, thank you. It's a sign of a great talk when there's great discussion like this. I'm going to take a couple from those who are joining us online, and I'll hopefully, if we have time, toggle back to the auditorium. This is from Kathleen. Outstanding talk, Asta, and thank you. Was going to ask similar to what Margaret asked in the beginning. Wonder what you think benefits of separate palliative team presence is for these patients with CCI. And what about addressing how preferences and values change while living with chronic critical illness?
Yeah, I think that's a great question. I think it is hard. I think it's both resource intensive, but also I think to a certain degree it is exhausting for patients, families, and patients themselves to undergo these conversations constantly. And so our approach really has been that, yes, they are involved, not almost as a stand, but they are involved in almost all the cases. And palliative care, routinely checks in with them, the frequency being decided based on the patients and their family preferences. I do think that there is a role for regular palliative care involvement, but I do think that there is, in some way, you need to strike a balance of giving the families time and space to digest what's happening with their loved ones. And so sometimes what I think has worked is regularly rescheduling revisits. So, we understand you need time to think about what we've talked about, but we will check in the next 2 weeks and set up a meeting to talk about this in person. Otherwise, we will be just available, routinely to just say hello or give you a quick update on the phone. And I think palliative care is very helpful with that, but I think what is more important is maybe the consistent staffing model, which we've seen families and caregivers develop relationships with the RTs, with the hospitalists and the APPs, and develop trust and sort of understand how the progress is going. So what was the second part of her question?
The second part was about how preferences and values change while living with chronic critical illness and how we might do better in addressing that.
Yeah, and I think that's an interesting question. When I look back at the literature on that, it's very varied, with one particular study actually saying that when they went back and talked to these patients who underwent prolonged mechanical ventilation, upwards of 92% in that study said they would do it again. Now, obviously, the caveat is clearly this was a population that probably did well. So they have a different viewpoint of this, and we don't know what we don't know in the population that didn't do well. But yeah, that was quite an eye-opener for me in that particular study. And so I think just like everything, this is going to be, it's different over time. And I think patient and families' preferences and values do change over time. And I think the only way we can keep in touch with them is ensuring that we have open lines of communication with them.
I'll take a comment from the chat. This is from the Norwalk group. In the 2013 JAMA study, a high percentage of patients were not included in because they've actually passed the trach collar trial and they didn't actually need the vent. This, of course, makes us think there may be room for improvement in terms of efforts to wean in the hospital, maybe even upstream, closer to where we are, I guess, in the ICU. And that maybe the actual needs for LTAC may not be as great. So it's a little bit of a comment, but we'd love to hear your thoughts on that.
Yeah, I think that was one of the most stark things, which is why when we looked at all these studies, we felt like trach mask was the way to go, because I think to some degree, when these patients have failed extubation, have undergone a trach after 14, 20 days of intubation, sometimes longer, I think all of us as clinicians are biased towards, well, they do need the ventilator. Let's be cautious. Let's not cause a complication. Maybe they'll plug up, et cetera. And I think that study really did show that as clinicians, maybe we do tend to underestimate what patients can do. I don't know if upstream in terms of whether when they are intubated, we are able to liberate them. I think that's a whole different conversation. With sedation, physical therapy, underlying cause for intubation playing a role in that. But I think we do know that once they have a stable, secure airway and you are monitoring them, you should be more aggressive about what they can do and do not hesitate to trial that trach mask. Is I think the biggest takeaway from that study for me. I think LTAC need, which was the second part of the comment, is more also related to physical therapy and rehab. And I don't quite see that going away very quickly.
Also, another thought is that a lot of the data you present is really old, right? And so I feel that our patient populations have really changed since
Yeah.
those initial studies have been done, right? We have all these new chemotherapies, a lot of
Right.
oncology patients, et cetera, et cetera. And I'm wondering do we have data here that maybe we can look at our data and get a sense and think about doing some kind of research or something to just get, with a more contemporary patient population?
Yeah, I mean, the answer is that we do have the patient population, and I think that we should do something with that patient population and look at the data to identify trends, maybe collaborate with another institution or something. But we do have big numbers, and I think to your point, Margaret, the patient population has changed. There was actually a recent study that says that patients that are getting admitted to the hospital are clearly more complex. They're clearly staying longer. And so the feeling that we all have is that, oh, these ICU patients are getting sicker is actually true. And so, yeah, I couldn't agree more that we do need more and maybe more contemporary data about this. And yeah, I think that we should be looking at our own patient population.
All of us who take care of patients with severe chronic lung disease have had this conversation
Right.
where a patient comes to you and said, well, I've been told if they ever get intubated, I'm never going to.
Right.
Or maybe some of us told our patients that. But I didn't see any predictive models
Mm-hmm.
to suggest that we actually know the answer to that question. Because obviously it's relevant. Like if you knew
Right.
that somebody was at high risk of prolonged mechanical ventilation on day one, you might make a different recommendation.
Yeah. I mean, I think there have been many predictive models that have been looked at to, in terms of even scores and things like that to sort of predict outcomes. But the problem with all of them is that now one of them have been shown to be very, very great, I would say. And I think in particular to sort of say whether they will require prolonged mechanical ventilation, there are some equations that I did come across, but again, these are very old. And I think the main things that stood out were that if you have a lot of comorbid conditions, if you're older, you've had multiple hospitalizations maybe in the previous years or ICU stays, you're more likely to develop chronic critical illness and maybe require prolonged mechanical ventilation. So I do think the predictive equations are there. I just don't think that we have very good data to back one of them up and say this is sort of the one that we should be using in all patients, which is, I think, the case for most predictive equations in even other disease entities.
We are almost out of time, but one last question from the online crew. I mean, this is like, I think, the $1 million question. Should we be traching patients sooner?
Yeah. So this is an interesting question. I think it's been looked at a lot, and I think the literature is fairly divided on this. So there was a study which was done to see if early, which they actually defined in some studies as within 7 days of intubation, traching patients versus late, which they defined as more than 10 days, was better. And they really, there weren't any consistently good outcomes to support more of the same. We actually did a really big literature review in efforts to see if we could improve that practice in our own ICU to then eventually downstream improve their outcomes. And you may have some smaller studies supporting maybe a little bit of a faster ventilator liberation or a faster rate of decannulation. But then other studies really not showing any statistical significance that we can't support one over the other. I think the bigger driver of that maybe is the underlying condition or underlying cause for intubation in these patients. And I think the second piece to remember is that it probably, what we do know of looking at those studies is that it's probably not best to wait for too long, because the longer they wait, they are getting more and more deconditioned. We are falling back on what we could be doing in terms of cutting back on sedation, doing PT. And so maybe we do need to do this quicker than our 14 to 21 day mark, but we can't definitively say we should be doing this within 7 to 8 days. So Margaret was just saying that one of our faculty, Chris Morton, looked at this in COVID patients, and he found a signal that maybe taking patients with COVID early would lead to less delirium, presumably due to lesser sedation, more PT, things like that.
Thank you, everyone, for a really robust conversation. And
Thank
thank
you,
you,
everyone.
Astha, for a wonderful talk.
Thanks.